Please unmute,
Sir.
Prashant.
Yeah, sure. Thank you, and hearty welcome to all our participants, and thank you for logging in late in the night. This is our 12th session of JLVC Grand Rounds, and it's basically a baby of Dr. Deepthi, and today she's traveling, and unfortunately she's not in a position to travel to join at this point of time. Hope she will join, and I'm just doing a locum job for her. Just an introduction to JLVC Grand Rounds before we start. We have no trade obligations, and we have attempted this as a collective learning, and we are attempted to be a center and a platform neutral type of a session here. And today we have a session on LASIK, and we have really privileged to have some of the very high volume and experienced surgeons with enormous experience. Dr.Kumar, Dr.G.S.Dhami, and Dr.Gaurav Luthra, and all of us will be moderated by our own Dr. M.S. Ravindra. Somehow we have not been very forthwith in advising Presbyopic for our refractive surgery patients, just like how we do for our ametropic patients. Various reasons, and hopefully today we'll have many answers. From one end of the spectrum, some of us are skeptical about Presbyopic. To the other end of the spectrum, where many surgeons have got the procedure done on themselves and the close relatives. So there's something that some of us are missing, and hopefully we get some answers today with this session. Just to create a context before I hand over the controls to our distinguished panel, I thought I will create a small context and give a small overview introduction about Presbyopic. So let me share my screen here. Just a very small presentation. I'll not take too much of the time, just a couple of minutes only. So unlike any other ametropia, we know that presbyopia is actually a failure of accommodation, which is a very dynamic and a vital process of shifting the distance to near. It is not a stationary ametropia, it's a very dynamic type of a loss. And what is important to realize is that the entire dioptric strength of the eye changes during the natural accommodation of shifting the focus from distance near. Unfortunately, we have not been able to replicate it. And so presbyopia continues to be a nuisance to every single person, maybe except the small myope like me. It's a nuisance to every single person. So since we are unable to restore the pliability to the lens, we have been ingenious in working around creating workarounds like reading glasses, bifocals, progressives, multifocals, and now these corneal procedures also. But what we need to understand is most of them, or almost every one of them, needs some type of an adaptation. This is a very important point to note when we are handling presbyopia context. And I think, yeah. So cornea is obviously chosen here because we have absolute precision in how we can control the corneal curvature within certain limitations. And the basic concept here is to increase the depth of focus or the depth of field. How we do this can be between the two eyes, like what we do as monovision, which is probably the only presbyopia correction that I personally do, which is simple and basic, to increasing the depth of focus and field for each eye, either by increasing the negative aspherical aberration, making a cornea hyperpolate, or by inducing a vertical coma, or creating a multifocal cornea. Creating an against the rule myopic astigmatism is another technique we routinely use in our cataract surgery, but whether it is successful in a refractive surgery setting, I'm not too sure. So, or we can use a combination of all these. Just before I finish this, I would just like to introduce the concept of depth of focus, because I think it's going to be continuously referred to throughout the session. So depth of focus is nothing but the distance between the farthest and the near points of the image plane on which the image can focus with an acceptable quality. On the image side, we call it as a depth of focus, but whereas on the object side, we call it as the depth of field. So what is the challenge here? The challenge here will be, how can we imagine a situation where all the points on the object side, maybe from 12 inches or 6 inches up to the infinity, can find a focal point on the retina? It would be probably a very bad, hopeless blur situation. So what we can do is we can create multiple focal points and allow the brain to choose what is relevant within the context. So what becomes important here is a neural adaptation. So how exactly we can balance the neural adaptation with the concept of glare and contrast sensitivity, loss of contrast sensitivity, is probably what the session is going to be about. So with that small introduction, I will hand over the control to Dr. Ravindra to moderate this session, to introduce the speakers. And thanks for that. Yeah. Dr. Ravindra, can take over. I'll just stop sharing the screen.
Thanks, Dr. Prashant. On behalf of Jyoti LASIK Vision Center, Bangalore, I welcome all the delegates who are here and who are going to watch this episode later. And we have three fantastic friends here as faculty at 9 o'clock in the night. And they're going to be with us for next 1.5, 2 hours, depending upon how interactions and presentations go. As usual, we're going to touch upon the clinical aspects and the personal experiences of the various faculty. And I would like to introduce Dr. Gaurav Luthra, who is my very excellent friend. He's a friend of probably thousands of people. His voice, which is to be heard, believed. He and he is excellent in, he is a director of Drishti Eye Institute in Dehradun. I visited his center, very charming family and the most respectful father has been an excellent ophthalmologist. His mother, very lovely mother, and his family, his brother is an ophthalmologist too, a VR surgeon. I was with him in his home for a couple of days, and I mean, he is a specialist. He's got his own concepts of the ophthalmology, and he is par excellent the cataract surgeon and the LASIK surgeon. They have got a fantastic LASIK center. He is very aggressive in his practice, and he's very aggressive in the adopting to the modern techniques, and that's Dr. Gaurav Luthra for us. And Dr. Dhami, very dear friend. I've seen him so many times in the conferences, very bubbling with joy. He is supposed to be, I've not seen his surgery, but he's supposed to be one of the best cataract surgeons in that part of, in our country, not in that part of the city. He's from Ludhiana, and Ludhiana, Punjab. And he's an excellent, right from beginning, right from the Allegretto came to India, right from the time the LASIK was born in India, and he was one of the premier LASIK surgeons in India. And we have very young Dr. Kumar and JLVC, and he's from Doctor Institute. He's the director there in Andheri, and he's a very innovative surgeon. His videos are it's worth watching his videos. Very innovative concepts. His video has got both visuals as well as the music. I always listen with great music. He comes with. He would have spent a lot of time in creating those beautiful videos, and I look forward to watch them again and again. And he has got laurels. He's got a training center which trains international ophthalmologists for LASIK. And tell us more about that, Dr. Kumar, doctor. How do you train your LASIK surgeons? What is the programs like in the time permits? And he's got a lot of achievements, a lot of laurels. He's presented in every conference in India and abroad. And that's Dr. Kumar, doctor with us. We're all waiting to listen to them. And we can start with the first presentation in the order that's been planned. Dr. Prashant, who is going to go first?
Dr. Kumar will present his thoughts.
Dr. Kumar, we're waiting to see you.
Good evening, everybody, and I would like to thank Dr. Ravindran. It's nice to have seen you again after our gap of otherwise we keep meeting in every conference. I'm very happy that I can see you today. This was a very interesting topic. So when I was asked to speak on this, I said, wow, this should be interesting. And I was a little hesitant because I said, am I supposed to speak the truth or am I supposed to not speak the truth? So of course, we are here to discuss what is really happening and what is not happening. I'll tell you the real science. First, we'll discuss a little bit of theory. and then I'll tell you my results and how long I've been doing this. So of course, this is the old procedure. Why is it not changing? 1 second, something has happened. I'll have to stop sharing. Okay. Sorry. So coming to today's possibilities, as already mentioned, what are our options really in reading glasses? How do we get rid of them? So excimer laser has got lots of options. So each technology, there is Schwind, Wavelight, Zeiss, Nidec, Bosch and Lomb. So all these excimer lasers have something or the other for presbyopia. There were corneal inlays. Some of us have done camera inlays. I have done cameras, 4 cameras, and there are other lenses. Of course, we have multifocal IOs, multifocal contact lenses, and dynamic approaches. So presbyopic corrections are lots of possibilities are there today. Coming to the next. Something is disturbing this. Okay, let's go to the next one. Can you see the slide?
We can see the slide, but it's not moving.
Yeah, it's not moving. I'm thinking what's happening. Okay.
So
as far as Presbymax goes, we have 3 basic options. I'm just going to tell you a little bit of theory and how it really works. 1 is micro monovision, 2 is hybrid, and 3 is monocular. As far as micro monovision concerned, this is since 2012. So we have the dominant eye and the non-dominant eye. What we do is the dominant eye is focused slightly more for distance, and the non-dominant eye obviously slightly more for near. So it's not exactly the same amount of depth that we are trying to get in both the eyes. In hybrid, we are almost getting the same depth in both the eyes. This was since 2013. And Presbymax monocular since 2016 is just like any other monocular vision. So the distant dominant eye is made perfect for distance, and the near dominant eye is made perfect for near. So it's like exactly like monocular vision. So Presbymax principles are read. It basically creates a bi-aspheric multifocal corneal treatment. Okay, so the center portion of the multifocal corneal treatment is for near, the peripheral is for intermediate, and the last part is for distance. So it's basically bi-aspheric, and it's like creating a multifocal corneal plane onto the surface. So how does it really work for distant dominant eye, non-distant dominant eye is what I want to tell you here. So when you have the distant dominant eye and the near dominant eye, as far as Presbymax micro monovision is concerned, the distant dominant eye, we will make it, suppose the patient is 6x6, we'll make him 6x6 part. So we are creating bit of depth, and the near dominant eye is the next part came after micro monovision came the hybrid. In hybrid, what has happened is difference here is monocular, the distant dominant eye, we are doing precisely nothing. And the near dominant eye works mainly for near. So this is how it basically works, and this is how it is. So basically, we have 3 options as far as presbyopic correction on the Schwind platform is concerned. So micro monovision, hybrid, and monocular. So which refractive error and how? So as you might have all realized that the near dominant, that's the non-dominant eye, is not really different in any of the 3 options. It exactly is the same. But the difference exists in the distant dominant eye. So in micro monovision, the 100% for distance. In hybrid, we are compromising the distance vision in the dominant eye. And in monocular, we are getting perfect distance vision in the dominant eye. So we have all the options to be concluded in the dominant eye. In the non-dominant eye, it perfectly works for near. So this is how the principle basically works. As you can see here, the dominant eye, the distance vision, here we have distance, intermediate, and near. So you can see the dominant eye, this is as far as micro monovision is concerned.
Dr. Kumar, your slides are probably not moving.
Yeah, only one slide.
We are with one slide which you initially started, which starts with presbyopia correction possibilities. Is that the one you are referring to?
Now I can see all.
No, maybe it's not moving here. Now we can go to the full screen. Now yes. We are seeing the 3-1, the Presbymax monovision. Now we are seeing
Now you can see all
overview
the
slide.
things.
We are seeing the overview
Now
procedure.
overview, right? Yeah. I'm wondering what.
Can you try to move it forward? I think, Kumar, you should stop sharing and then share it again. That would be the best way.
Let me do that. I'm not even able to surprisingly exit.
Something must be covering it.
Now I can. Shall I stop share?
Yeah.
Sorry. Oh God.
Yeah, we
Now
see
this
the
is better.
Presbyopic, the overview slide. We are not seeing anything now.
Kumar,
Overview.
Blank.
What you have to do is you stop screen sharing, then go to your keynote, put it onto slideshow, then exit that and come to Zoom. Okay. By swiping your 4 fingers up on your touchpad. Okay. You leave the keynote on presentation mode, then come to the Zoom
How
window
about you?
and share it.
It's blank right now.
Oh wow. Okay. Okay. Tell me what you want me to do now.
So you stop sharing.
Stop sharing. Okay.
Then on your computer, you go to the keynote and go into the presentation mode, which means on the slideshow mode.
Done that.
Okay, now with your 4 fingers, you swipe up so that your screen changes to the Zoom screen.
Swipe up.
Find the Zoom screen now by swiping up or down, whatever.
And then share screen.
Then share screen. Now should have been playing already.
It will be like this.
Okay.
Does it show?
Yeah, okay. Okay, I think we are able to see it. Maybe now you can play it and see it should work.
Not working. Okay.
I think you can show it like this. Just remove. Yeah, I think this is fine. Yeah,
Okay.
now we can see it. Yeah.
Let us keep it like this then.
Yeah.
So what I meant was just repeat a little bit that Presbyopic basically has got three options: micro monovision, hybrid, and monoocular. Okay, so as far as micro monovision is concerned, the distant dominant eye is treated both for intermediate and distance, and the near dominant eye is completely treated for near. In hybrid, there is a little compromise for distance because both have equal depth of vision, and monoocular is exact single. So the distant dominant eye is treated completely for distance and the near dominant eye is treated completely for near. So there are three different options of Presbyopic on the Schwinn platform, and all of these options create a bi-aspheric multifocal corneal ablation. So this is how the slide is, that the center is for near, the peripheral is for intermediate, and the last part is for distance. So this is basically creating a multifocal corneal surface. Now, as far as the different treatments go here, as I said very clearly, that the Presbyopic, the first part is the non-dominant eye approach remains the same in all the three options. Whether it's micromonovision, whether it is hybrid or monoocular, the difference exists in how we treat the distance eye. So the dominant eye, that is in micromonovision, is treated 100% for distance. In hybrid variety, it's 50% for distance. And monoocular, we are treating it completely zero for near. So monoocular, one works for distance and one works for near. This are the three different options that we really have. So this is how the vision is. You can see the dominant eye, that is the distance, intermediate, and near. So the dominant eye works perfectly for distance and little helps in the near also. This is in micro monovision. In hybrid, you can see the dominant eye works for distance and intermediate, but does not help in near because the non-dominant eye will work for near. And in the variety of monoocular, the dominant eye works for distance and the non-dominant eye works for near. So as far as is this treatment pupil dependent? 100%. Like any refractive IOL or a diffractive IOL, this is a refractive type of treatment on the corneal surface. It is entirely pupil dependent. So you have to see the size of the pupil. Very, very important take-home message that the photopic pupil has to be between 2.5 to 3.5, and a scotopic and a mesopic pupil, that is low pupil size, should be minimum 4.5. So When we are treating monoocular Presbymax, that's the last part where the distance is for the distant dominant eye and the near for the near dominant eye, it is less pupil dependent. Obviously, the extended depth of focus naturally increases as the pupils become smaller. So in small scotopic pupils below 3.5, any decision for Presbymax should be monoocular. And that because it is not getting affected by the size of the pupil, and that's the reason why that should be selected. Very important is how to measure the pupil. So there are lots of ways dynamic pupil can be measured on a Cirrus or on a wavefront analyzer, and you can get a photopic and scotopic pupil size. And high photopic conditions post-operatively are optimal for reading. So this is another message we have to tell our patients, that after surgery, you should have good photopic conditions for reading. And if you go out in sunlight, it is good to wear glasses because your pupil dilates. So when you wear sunglasses, your pupil dilate and your distance vision will come into play. As I said, it's a multifocal corneal treatment. When the pupil dilates after you wear sunglasses, the peripheral cornea comes into play, and that's the reason why this is important. So here we can see that between 3.8 and 4.5 millimeter, the distance and the near vision all are very, very good as far as it goes. Now, what are the patient criteria? Of course, the patients themselves should be very motivated, accepting, and they should be willing to accept some trade-off for distance and for near. If they are not accepting this at all, that no, they want perfect distance vision, they want perfect near vision, they are not the right candidates for a multifocal corneal treatment or for Presbymax. Best thing would be to do a contact lens trial, test for monovision, test for multifocality. And don't forget that we never use an optical zone on the Schwinn platform more than 7 millimeters. So corneal spherical aberration should not be more than 0.5 microns. If it is so, then we cannot do a Presbymax. And this can be, of course, judged by the corneal topography, which will actually tell you what is the spherical aberration there. And chair time is very, very, very important. So as far as multifocal corneal treatment, contact lenses are concerned, in Presbymax monovision, hybrid or monoocular, we actually put multifocal contact lenses for the patient, let them use it for a week. If they are fine and they come back and they say they are fine with that quality of vision, then that person is a candidate for Presbymax treatment. If they do not accept this and the mind does not accept this, then they are not the right candidates for this kind of a treatment. As far as trying to do the same simulation in glasses, very, very difficult. So if you say that you did a trial with glasses instead of contact lenses, because nowadays we get multifocal contact lenses also, the same thing result will not be there. So in spectacles, multifocality cannot be simulated like contact lenses. So preferably avoid it. But if you really want to try a spectacle, then you can do that you slightly in the dominant eye undercorrect it so that the patient reads only 6/6 part or 6/9, and undercorrect the non-dominant eye so that the patient reads near. So this is how you can give glasses to the patient. It's just like a simulation that this is how the patient will see after surgery. If that the patient accepts, then he's the right candidate. As far as the treatment decision is goes, now why do we have these three options in Schwinn platform? The Presbymax micro monovision is very well accepted for hyperopia below +4. Hybrid is mainly for myopic patients who are willing to possibly lose a little bit of distance vision. And Presbymax monoocular is, of course, for true emmetropic patients, high hyperopes of more than +4, and where we are not much bothered about the pupil size. As I mentioned before, the pupil size is crucial, but when you do Presbymax monoocular, the pupil size is not all that important. And that's the reason why these are the good candidates for that kind of a treatment. As far as the market is concerned of monoocular, the market opportunities for Presbymax monoocular are a lot, because surgeons who are not willing to do multifocality can do anyway. Many of us do that monoocular vision in implant surgery itself. So this is one option that they can have. And surgeons who strongly advocating classic monovision, they can go ahead and do this. So classic monovision Presbymax works very, very well. As far as the options of optimization are concerned, Presbymax can be repeated. Yes, the beauty of this is, suppose we treat the patient at 45, patient is very happy till 49, you can repeat this treatment, okay? But when you repeat the treatment, it has to be a corneal wavefront guided treatment, and the pupil offset has to be looked at. Another thing here is the optical zone of the previous Presbymax treatment that we have done should be the same that we do in the repeat treatment. And pupil offset should be set as the same. Remember this. Now let's presume that the patient is unhappy after 6 to 8 months of your Presbymax treatment. The beauty is the Presbymax reversion option is there. So you really don't have to click much. You get the correction factor. There's a button that you click. It says reversal and the whole treatment gets reversed. But don't forget, in our system in Schwinn, we have to give 6 months for neural adaptation. And then only if the patient is unhappy, we can do a reversal. So here you can just an example that when we are doing a Presbymax reversal in the non-dominant eye, you can see that we are treating the center and not treating the periphery. This is just one example of Presbymax reversal. The first one is pre-op, where you can see the coma is 0.428 and spherical aberration is 009. Post Presbymax, obviously the spherical aberration is going to go up because that's what we want, and the coma also goes up because that's what we are creating. Now let's presume that this patient is unhappy. We do a post Presbymax reversal, and you can see that the coma has gone down and the spherical aberration also gone down. So this is quite possible in today's technology and science. So if the patient is unhappy, we can reverse this whole treatment and get them back to what they were original. Now, if the patient has had previous laser surgery, can we do Presbymax? The answer is yes. And if the patient has had previous cataract surgery with a monoocular lens, can we do Presbymax? The answer is yes. So I have some data on that, and I'll show you the data, very, very old, but I'll tell you the details. Now, let's presume this patient's develop cataract after some time. What are we going to do? Technically, what we are supposed to do is use a aberration neutral IOL. So we can't use a aberration correcting IOL, and we cannot use multifocal IOLs because there's already a multifocality created onto the cornea. As far as IOL calculations for this go, it's a completely entirely different story, but ray tracing or a pentacam will give you total net power, and then aberration neutral IOLs can be used for this for calculation. So there is a huge Presbymax guide as far as there are contraindications and indications are concerned. But as far as exclusion criteria are concerned, ocular pathologies, this is like any other pathology. If the patient has very high expectations, do not take this patient. If the patient has a very focused, close work for long number of hours, they are not the right candidates. And if the patient is still not willing to wear a little dependency on glasses, they are not the right candidates. So like any other exclusion criteria, it's the same. As far as inclusion criteria is concerned, the rest of it is the same, but most important is pupil size. So here we see the photopic pupil and the scotopic pupil, and acceptance to intend multifocality when we use a multifocal contact lens. If they pass this test, they are the candidates and who will be happy with this kind of a treatment. Treatment planning guide is a lot. I will just give a little outline. Again, the beauty here is we can apply any type of treatment. So we can do surface treatment Presbymax, we can do LASIK Presbymax, we can do femto Presbymax. So it is not that we can do only one particular thing, we can do any format and we can use Presbymax. There is something called a static cyclotorsion in the Schwinn platform where it actually takes the images of the multiple iris crypts and then that is superimposed when the patient lies down, and that takes care of cyclotorsion at the same time as far as the treatment goes. There is a surgeon, not a surgeon factor, there is a nomogram that we use in Schwinn platform. So you have to decrease the addition by 0.10 per diopter for hyperopia, increase the addition by 0.05 for each diopter of myopia. So these are adjustments that they recommend as far as surface, myopia, hyperopia or pseudophakic patients is concerned. Optical zone should never be more than 7 millimeters. That's another recommendation that they do. So this is basically a decision tree. So anisometropia more than one diopter, if not tolerated, no Presbymax. If tolerated and the photopic pupil and the scotopic pupil is what the size we want, then we have a choice of micromonovision or hybrid. And if both of these are not suiting, then the best option is Presbymax monocular. So as I said earlier, that the Presbymax monocular is not dependent on the pupil size at all. So they are the right candidates for that. There is one conclusion here that there was a study done that monoocular gives the highest safety. So Presbymax monoocular with no loss of vision or more than 2 lines, the patients are very, very happy. Reversal treatment after 6 months, there was 0. And Presbymax hybrid gives the best binocular, uncorrected, and uncorrected visual acuity for distance and near. So as far as monocular is concerned, it is considered to be one of the safest techniques. I'm going to do one more presentation, share one more talk. One second, I'll stop sharing this. I'll share one more screen, which is my initial talk of, you'll be surprised when I started. Let me shut this. Oops. 1 minute. I'll just stop for a second. So this was one of my initial Presbyopic presentations which I had done, and this was reported by me many years back. I'll just share this one, and you'll be surprised what I've done when this was way back when. Can you see this presentation?
Yes, Dr.
Yes, sir.
Kumar. Yeah.
So this is pseudophakic Presbyopic. This I did in 2010. So that's when it actually started. We have the Schwinn platform. There are lots of advantages of the Schwinn platform because it does 6-dimensional eye tracking. This is the 6-dimensional eye tracking. So we have the roll, we have the tilt, we have the cyclotorsion, and we have the Z-axis. So I personally am the opinion that this gives the biggest advantage over anything else. So if the patient is pseudophakic and wants multifocality, we have 2-3 options: explant, reimplant, add-on IOLs, or a multifocal corneal treatment. So this is a certificate I got from Schwinn in 2010, February 18, that we were the first in the world to do presbyopic pseudophakic treatments. That is when George Alio had invented this, and this was the same treatment that we were doing even today, but little better options that we are giving to our patients. Now, this is my little bit of patient data. You can see the spread. So basically, this was a data of only 5 patients that time, 2 Reina, 1 Alcon IQ, and 1 single piece. And all surgeries were done 3 months later. All needed an advocate because they're monofocal IOL patients. As far as all the patients had a thicker cornea, all were microkeratome. I used either a 110, 130. We used the aspheric profile, optical zones from 6.5, depending on the pupil size. And we had SCC data for everyone. This is old data, but I'll tell you the summary of the whole story. 1 female for age group between 38 and 72, bilateral treatments done at the same time, the same surgeon. One of the patient had a YAG capsulotomy. Obviously, there was no diabetic retinopathy or glaucoma. So this is a pre-op data. You can see there is a large scatter, and this is a post-op data where you can see that all of them could read N6. But let me tell you, how does a topography really look? So this is a pre-op topo. And when you do the treatment, post-op, there is a little bit of steepening in the center. This is another patient's pre-op, and this is the same patient's post-op. So in post-op, if you do not see this steepening in the center, patient is not going to be able to read N6. That much I can assure you. And this is post-op 1 week, 6/9 for distance, and N6 for near. And this is the same thing post-op the other eye, and this is the same other patient's other eye. So here, as you can see, the pre-op data, the spread out, the scatter is a lot, and then the post-op, the scatter is much lower. So Presbyopic at a glance has advantages. This is the advantages that you can see. So I'll just show you, does it work? Patients asymmetry for distance, they are happy. Hyperopic and astigmatic patients in my hands are happier than the myopes. Near vision is pure magic. In fact, I've done live surgery of Presbyopic with Dr. Grewal in Chandigarh. And 1 hour after my surgery, the patient could read what was written on the bottle. So that was the magic for near vision as far as Presbyopic is concerned. I don't know whether this will play, but this is one of my very old videos. You can see a pseudophakic patient, and LASIK on that, there's nothing really different. So you can see the shine of coming out from the lens surface. There's nothing different that we are really doing here. Just make a flap like what you would always make and do the laser. So there's nothing different you can see. There's really no learning curve. But there's one thing that I do in pseudophakic patients is put one drop of methyl cellulose. Now you'll wonder why, because they are elderly, their basement membrane is not all that strong. So once you got that, I put one drop of methyl and then I put the saline. This prevents the friction of your microkeratome head, and that will sometimes prevent the detachment of the basement that can sometimes happen in elderly patients, in spite of their vitamin D being good. So this is just like normal. This is a Cariazo pendula, Schwinn microkeratome. I'm using this in the last 10, 15 years. Very happy with it, going on well. It always makes a superior flap. You can make any kind of flap. You can see the IOL now. And once you lift the flap, just go ahead and do the laser. So there's nothing different. There's no learning curve. The calculation is according to the technology that the machine does for you. So does this work? The answer is yes. It does work beautifully. It has amazing results if you pass each test. But the problem here I find is there's a lot of limited applications. Means I always apply this between patients between age of 45 and 50. Before that, I'm not very happy. After 50, I give them options of CLE and a multifocal or extended depth of vision IOL. Age range, too many filters like pupil size, hyperopia, myopia, astigmatism. So there are too many filters. If that's why the number of patients, I'm not having so many. But all those who get it done are happy. The beauty is that if the patient is unhappy, then we can reverse it. Unfortunately, in my initial series, my retreatment rate was very high, and I thought Keki Mehta also had reported a very high retreatment rate of almost 18%. Now the retreatment rate is much lower after the micromonovision and the hybrid variety. The retreatment rate has dropped to about 5%. Unfortunately, in Schwinn platform, even if you retreat the patient in 3 months to 4 months, you have to pay for it to the company. So that's getting it costly and more expensive. And as I mentioned, the beauty is that it is reversible. Thank you all, and sorry about the glitches.
Thanks, Kumar. That's a complete presentation. Really enjoyed your experience as well as the theory behind it. And can you tell us, before I go to the next one, can you tell us what is the ratio of the three modes of treatment, micromonovision, hybrid, and the other one, the monovision? So what if you've done 100, how many of them belong to each category?
Sir, I completely don't do myopes, and I do not do e-micropes.
So hybrid is out.
Yeah, so I'm selecting only hyperopes and astigmatics.
Okay.
So all of them, hyperopes are happy with micromonovision. Okay. So 90% would be micromonovision, because I personally feel when we do a normal LASIK, also for a hyperope, they are very happy because they can read, because of the center correlation that they're getting, because we're treating the periphery. Correct. So here I think we're just exaggerating that. Unfortunately, George Alio has exactly opposite results. His myopic patients are very happy and hyperopic patients are not happy. But I don't know, I'm personally of the opinion myopes tend to compare their vision with nearsightedness. So when they remove glasses and the quality of sharpness that they get for reading, they normally tend to compare with that quality. And that's the reason why I'm not too pushy for myopic patients to do presbyopic correction.
Very good. Good take home point. The second is you've been doing it for such a long time. I'm sure that you had an occasion to follow up these topography pictures on a long time. Are these pictures stable over a period of time, or the epithelial modeling will, cover up some of the changes that you produce in the cornea?
Sir, I personally feel it's not only epithelial modeling, it's even stromal modeling. So that may explain why they have a high retreatment rate. This is my personal opinion. I may be wrong in my knowledge or my information. But the explanation here is that some of them, if they don't have that red dot in the center, which I showed in my topography, which is actually what we are creating in the center, then those patients will 100% need reading glasses and won't be happy. So they do remodel over the number of years, and that may give one explanation why presbyopic LASIK in multifocality is not all that very popular worldwide.
The third question I would like to ask you, and later the other faculty also, is that uh, how do you decide how much of hypermetropia to be treated? Like they're all hypermetropies, most of them, and they're all above 40 years, and much of latent hypermetropia has become manifest now. But how do you ensure that some amount of hypermetropia is not hidden behind which you're not detected while treating?
So on the Schwinn platform, sir, what we have to do for hyperopic, whether it is after 40 or before 40, the rule is dilated subjective acceptance is what we have to enter into the system.
Would
So
you have
then we
any
are not
would you
worried
have
about.
any tricks about dilatation? Would you use cyclopentolate or tropicamide or homotropin? Is there any in your clinic what do you
No,
practice?
so normally tropicamide plus is good enough after 40. And if we find a gross difference between the PGP and the dilated acceptance and what the patient was accepting non-dilated, then we'll look into it a little more deeply. Otherwise, we are quite happy with this.
Fine. The you mentioned about regression in some patients, and you said even Dr. K.K. Mehta had regressions. Can you identify the patients who actually regressed? Is there any difference between those who regressed, the power-wise, or the care reading wise, or the treatment option wise, versus those who did not regress? Off the cuff, you don't have to have a scientific study on it.
Yeah, so what I have seen that so they, in 6 months they say we can't read what we could read sometime back. It's very simple. And then when we do a topo, we don't find the red spot.
What
So
changes
that is,
happened over 6 months in either cornea or in the refractive
frankly,
status?
so that time we were not doing epithelial thickness mapping. Nowadays we are doing epithelial thickness mapping. So in fact, those patients who are pseudophakic have disappeared to follow up. And recently I'm doing normal hyperopes. I'm not doing pseudophakics because we are doing a lot of extended depth anyway. So I feel that if those patients I can call back and find out whether something was happening at the epithelial level or everything is fine at the epithelial level.
Fine. Okay. Good. Good. Very good. And before we go to the next one, the ratio in your clinic, if you have done 100 LASIKs, how many of them are myopes? How many of them are hyperopes? Approximately, how many are presby? Just to understand the intensity of the the need for presby LASIK.
So presbyopia would be hardly, I mean, I would do one a month,
Okay.
not more than that, because as I said, there are too many filters, sir, because pupil size, I don't do below 45 and I don't do above 50. So that again becomes limiting. Again, I have to select only hyperopes or hyperopic astigmatics. So there is again a limitation there. And so the volume is very, very, very less because in my hands, the results are good only in hyperopes.
Okay. Fine. I think we have
Recently, sir, I'll just give one example. One of my patients, very unhappy after Presbymax, a hyperope, but you won't believe, sir, after 3 months, she came smiling. So her neural adaptation took 3 months, but till then I was not smiling. So, I mean, this is one issue which was the longest period I ever had in any patient. But as rightly mentioned, that I think 6 months should be given to them to neural adapt.
How differently your counselors counsel these patients? Are they very aggressive, or they know that you don't like, so they don't counsel presbyopes as much?
Yeah, I think we should only do the counseling, and I think from our body language, only patients can make out that this guy is okay.
Okay, fine. I think the next talk is by Dr. Dhami or Dr. Gaurav.
Dr. Dhami with his Alcon platform.
Yeah.
Dr. Dhami, we are all waiting for you.
Thank you. I'll share my screen.
Dhami has an Allegretto unit, and he uses very similar. I learned the trick of doing presbyopia much from him. He has been doing it. He's one of the favorite. He would have done much more presbyopia than anybody else, if I'm right. And he prefers to do it in all Punjabis. Whoever comes there above 40, he would like to do a presbyopia on them, if I'm right.
Just wait. I am unable to share. I just gone off.
You're not shared at all. We still
Yeah,
see your.
I was not getting it. Give me time, please.
Take your own time. That's the advantage of starting at 9 o'clock.
Yeah.
There is no next session.
I'm not going back to my.
You're using Windows or Mac, sir?
Yeah. No, I am using.
In the meantime, if I can ask Dr. Kumar, he mentioned about Air Optics Aqua multifocal contact lens. What is the principle of that particular lens? How does it induce bifocality or multifocality, Dr. Kumar? Is Dr. Kumar?
What to do? Naveen Bhai.
Take your own time, Dr. Dhami. Do you want Dr. Gaurav to come before you in the meantime?
Just a minute.
I think in the order, I think Dr. Dhami should come first because I've prepared myself accordingly.
Okay.
But
good enough.
Sir, in the meantime, why don't we hear a little bit from you? I mean, I'm really keen to hear your experience, even though Dr. Dhami is going. Okay, he's able to share his screen.
Yeah.
Perfect. Just cross it out, sir.
Okay.
No. Just cross it out. Yes.
Just cross it out.
Now cross this also on the top right. No, just go a little higher on the right. On the right, sir. Just beyond the smileys. No, not that one, sir. Just little above to this on the right. Oh, so cross this out also. And now yes, perfect.
Yeah.
I can see Abhinav.
Yeah, he's there to help me out.
Hi, Abhinav.
Dr. Ravindra, I heard a beautiful talk from Dr. Kumar. But the only privilege we don't have is we don't have Shwind, we don't have Zeiss, we don't have Prespon. We are only with Allegrato EX500, and that gives us a thought process as to how to proceed with presbyopia. Am I audible and visible?
You're audible, sir, but the voice is cracking.
I think the moderator can mute everybody else except Dr. Dhami. There's another voice coming up. Kindly mute your audios, please. All the delegates.
I think it's clear now.
Everybody is muted. Everybody is muted, except the speaker.
Okay. Actually, we never had a chance to think about presbyopia in users like Allegrato. Then we shifted to 400. Then we shifted to EX500. But all the time, we always thought we can do it. And though Dr. Kumar showed wonderful slides with his way of doing it, how we created monofocality to multifocality on the cornea and went very safely with presbyopia treatments I'll be talking about. That means you don't have any software for presbyopia, still you can do it on a machine like EX500, all Allegrato setups, whether it is 200, 400, or 500 now. To me, it was a change to customization. Everything was changing. That time when we were changing, presbyopia treatment from Zeiss or Schwinn were not there. But we were determined to change in refractive surgery, customize a change which would bring definitely other companies into line. We had a wavefront optimized platform, wavefront guided, topo guided, but the least used was the custom queue protocol, which we went through. And it was probably 2008 when we were in Budapest, when we first got the nomograms, how to create a profile for presbyopia in our patients with nothing more than what we had. it had become an era of eagle's vision when everyone was talking about something beyond 6'6". But we were talking about patients coming to us in the age of presbyopia or pre-presbyopia, how to go with them. What really we needed, what really we wanted to know, all these slides will guide you to what we planned and we were successful. It was not a new concept. Alligator users had already shown, written, published articles how to get a concept of presbyopia without having a definite software in our machines. Let's see how we went. Well, when we talk about presbyopia, it's just a question of few spherical aberrations we need to create or extrapolate our corneas. Spherical aberrations were higher order aberrations caused by unequal convergence of the central and the peripheral rays passing through the refractive surface of the eyes and striking parallel to the axis. There were total spherical aberrations defined as the sum of the spherical aberrations of the anterior and the posterior surface of the cornea and the ones introduced by the lens. These affected our image quality. Just to understand, we have a zone which is pupillary area. We can only manage something in the pupillary area, and how we did it, just to begin with, we understood there were rays which are coming to focus in front of the principal focus. There were rays coming focus behind the focus. So we had something known as positive spherical aberrations and something as negative spherical aberrations. Now what relationship did these spherical aberrations had with the pupil? Dr. Kumar showed the only difficulty is the pupillary diameter of the existing patients. And unluckily in India, we have a pupillary diameter which starts from a very 2 millimeters to hardly going to 4 millimeters. So decreasing the pupillary diameter, the peripheral rays disappear, and the benefits of what we are going to talk just decrease. And above it, when you accommodate, the pupil still becomes narrow. And every refractive correction on the cornea increases the positive spherical aberrations, which still worsen the symptoms. All these problems we needed to understand. Now, we have a pupil, which is this, and it is emetropic in this area, which is the apical, the paraxial zone. It is slightly hyperopic in this area and slightly myopic in this area. These are the higher order aberrations we could play with. And remember, only in the pupillary area. And once a spherocylinder, and this patient is one who had a visual acuity of 6.4, 6.5 when corrected retinoscopically. When we correct this sphere cylinder, virtually all effect of the aberrations disappear. So what we had some inequalities in the pupillary area, inequalities in the center of the pupil, inequalities at the margin of the pupil. We had a variation. We had imperfection in the pupillary area. The imperfection gave us an idea. If you modulate this imperfection into one similar line, create similarity from the center to the periphery of the pupil or the margin of the pupil, we could create a multifocality in this area to give a presbyopic effect without anything else than what we have in a machine. What we have next? We created a myopic effect in the center of the pupil. This is caused by increasing the negative spherical aberrations. How to go about it? How to treat it? How much we can increase and how much we can do it? And what is the way out with this? We have nothing extra than our machine gives no other access software. So we thought about what we can do. This is just a diagrammatic representation of what can be done. We have a pupillary area. We have rays from the center coming to focus in front. We have the peripheral rays coming into it. Can we treat them? Can we modulate them? Yes. By modulating them, we can create something known as a presbyopic effect. But creating a hyperpolate cornea, creating a negative spherical value, which we will see how much, did not do something. We needed added correction for the accommodation which has been lost in these patients. Again, the pupil size plays the biggest role in our corrections. As clearly mentioned by Dr. Kumar, I think well elaborated, I needn't talk here. Now, we had only one thing with us that is called custom Q ablation profiles in a machine. We hardly use it, but I think it is the most important profile to get used to it, to treat normal corneas, to treat myopes, to treat hypermetropes, and to create a presbyopic profile as we go by. What we need to do, we need to correct higher order aberrations. We need to induce spherical aberrations. Expected contribution of variation in spherical aberrations due to induction of new apical aperture and a sphericity Q was not fully understood. We really went through all the literature, how to go about it, how to treat, how much to treat, and what to create to get something to create a presbyopic pupillary zone. Now, what was it? All corneas do not have a similar sphericity. We wanted to match the preoperative Q value to the postoperative Q value and thereby maintain it and then create from it a hyperpolate cornea, giving us a multifocality in the pupillary area. Now, this was the mathematical model we came across. Caton and al. Have a great work creating a presbyopic in machines which really don't have a software, directly jumping, switching on a button and going to presbyopia like Schwinn or Presbyopic. Now they put forward us a mathematical calculation where the maximum negative spherical aberrations of 0.4 to be created in the pupillary area, an area which we wanted to treat. But how? How much Q value we should increase to get this area? And the value finally came out to be a delta Q of 0.6. This gave us a very good answer. We could treat any eye. We could treat any eye. We could manipulate Q value. We could understand how to increase the spherical aberrations to give us a presbyopic profile without having a software. In young patients, this added advantage of depth of focus, reduced glares and halos. And in presbyopic patient, it increased the depth of focus and a good intermediate vision and a cushion for near vision. Just to recall, we talked about a slide where there were imperfections in the pupillary area, giving us a depth of focus and a defocus to a normal person. Now, if this imperfections in the pupillary area or higher order aberrations can be manipulated by a simple technique of custom Q treatments, we were able to reach a good result, even creating a good multifocal profile in the pupillary area. We created a central apical zone which had a negative value. We created a paracentral zone just like a multifocal eye. So it was multifocality in the pupillary area on the cornea. What principles we thought of? We wanted to avoid inducing spherical aberrations. We wanted to reduce the existing spherical aberrations which were positive. We wanted to induce necessary spherical aberrations, and we have the idea. We knew that if we treat the asphericity of the cornea, we can exactly count and label what we have created. That's what exactly Schwind and Presbyopic do when they have their modules operating directly. To add to this, we had to add a monovision in small amounts, because these aberrations alone will not be able to treat the presbyopia or the lost accommodation in the patient. What is custom Q protocol? It's a software. It's in every machine, whether you use it or you don't use it. But we really exploited it. It accepts correction of sphere and cylinder in the steps of 0.01. It accepts minor cylinder and astigmatism, converts the cylinder to the necessaries to be treated. It enables all the fine treatments. Even the optical zone can be managed in the sept of 0.1. It enables file adjustments and transition zones. So it virtually is recommended to be used in all profiles you want to work in refractive surgery. It's an ideal recommendation, and it conserves the profile. Now, what we wanted to do? We wanted to do what Dr. Kumar virtually said. He wanted to create a negative value in the paraxial region, a myopic effect in the paraxial region of the pupillary area, and in the paracentral area of the next part of the cornea. He wanted to demyopinetize, means he wanted to create a little hyperprolate cornea. He wanted to give a hyperopic effect which will not affect the distant vision. And we wanted to match our Q value to create a value of C4 in the cornea. But this all needed increased ablation depth, which changes after altering the Q value. And therefore, we got to compensate it. So we found a stage where we could increase the delta Q. The delta Q means the Q value difference between the existing and the final we want to create by 6. But in doing that, we were consuming extra tissue. We wanted to compensate for it. And there came the use of SS nomograms. We were able to calculate what we wanted to treat. Now, just treat without a software from the company. Now, let's see when we treat hypermetropia. Hypermetropia are ideal patients that Kumar mentioned. They were ideal to treat. They are people who have lost their distance and near vision both, and they're the happiest patients. And they're quite easy to treat. Let's see a preoperative patient of this example. He had a distant correction of +2. He had an addition of 1.5. He had a preoperative Q value of -0.20. What did we do? We wanted to induce delta Q of value of -0.6 to -0.7 extra. This was required to create a central apical zone which becomes myopic once the patient is looking at a distant object. And we always worked at an optical zone of 6. Now, in a dominant eye, we just did a wavefront optimized treatment or a topo-guided treatment to give the patient a perfect distant vision. What did we get? We got a postoperative Q value of -0.8. Target refraction was -2.5. And we really created a central zone on the pupillary area, which was myopic and which served as a near vision. And we created a peripheral zone, a paracentral zone on the pupillary area, which gave a distant acuity. So patient really did not suffer from distal acuity. It was practically a multifocal zone in the pupillary area, an area which we have to use. And there was a perfect increase in depth of focus. And in the emetropic eye, that is the dominant eye, the patient Q value was untouched and he was corrected totally for the distant vision. Now, Dr. Vindra was asking how much hyperopia we correct. I have been trying to correct the full cycloplegic refraction, because otherwise the retreatments will increase very fast. So this was a hyperopic case, but this was not yet. How to treat normal corneas, myopes coming to you, hyperopes coming to you, patients coming in the edges of pre-presbyopic areas, presbyopic patients, and pseudophakic patients. We utilized the value of SS nomogram, which was introduced to us for a long period. The only thing which we didn't have was how much Q value we should create. Now, with mathematical modules of Gatindal, we know how much to create. But what we practiced was how much ablation depth we were doing extra. And how much we were creating extra myopia in the patient. So we could titrate the final refraction very well with SS nomogram, decreasing the amount of presbyopia we want to treat. Now take this patient who is myopic by 5.5. Now he is in the age of about 40s. If you treat him in total or create a monovision for him, I think he will not be satisfied. What we did, we added his presbyopic effect. The calculation was this. To this delta Q of the difference between, we were aiming at -1 in this period. Luckily, we always had a delta Q of difference of 0.6. We didn't know whether this was accurate or, as already displayed in the earlier slides, was wanted, but we were right. With this, we got a factor which we had to treat, we had to calculate. Applying this factor from the SS nomogram, we will calculate what we wanted to aim. So this is what we treated finally by the custom Q treatments on the patient's non-dominant eye. So we had a point, we had a platform, we had a software which did tell us what we are going to get. And did we really get? Yes, we always got it. Hyperopic were the most happy patients because they were getting both of the worlds. They were getting a distant vision, they were getting a correction, and we were already treating them with full correction, which did give a little dissatisfaction in the early periods because their dominant eye had become little myopic because of the latent myopia being corrected in total. But that was only for a little period. In this treatment, patient required neuroadaptation to a very little effect. Again, we had what I said, we were with the nomogram, we had a delta Q, which was 0.6. So we were rightly treating even with the SC nomogram. And what we treated after applying the nomogram was this. It was a little mathematical calculation, and suddenly after doing a couple of cases, we could get a direct answer. Every optometrist could calculate, we are going to treat this. So this was all on custom Q profiles of our machine. But it's very important, as mentioned, who to treat and why presbyopia treatment really did not become popular. We never advertise that we are treating presbyopia because we really don't have a software which names that treating presbyopia. We are just managing our patients in a particular age who come to us. Now, when you really plan presbyopia, in a presbyopic patient, ocular dominance is a first thing to find out. It can be judged merely as the patient sits next to you on your seat. Ask him to point at a figure. He will definitely point with his dominant hand. Whole test, this is what we repeat, and very accurate. A patient is allowed to hold a card which has a central hole. He reads the distance charts on the central chart with both eyes and suddenly brings this chart near to his eyes. The eye to which the chart comes is the dominant eye. Of course, a leading question can be, how do you click your camera? The patient will say, I click like this. A dominant eye is the one which clicks with, he always clicks with the dominant eye. And of course, how will he shoot? That's his dominant eye. But things don't end here. We needed a blur test. Moment the patient sits on your chair, this is the first thing we should do even before talking to him about presbyopia. We do a cross blur test very fast. The dominant eye is corrected for distance. The non-dominant eye is given a near refraction. He can read the distance chart with the dominant eye. He can read the near chart with the non-dominant eye. He is very happy when he's looking up at a reading chart. But as you occlude the non-dominant eye, he is unable to read. The smile on his face will tell you if the patient is ready for surgery or not. But a promise is just an age to cover up till he really develops a dysfunctional lens to be removed by a multifocal IOL. Now, see, we really, when we came down to working on custom Q, it was just not the presbyopia. We have patients who will never be happy, all myopes in the ages of 35 to 40, who are bound to be unhappy because they are entering a presbyopic age. These were the patients we love to treat with custom Q, following the SS nomogram, not increasing the Q value or a definite value. That patient doesn't become as unable to read moment he sees his corrected vision on the very first day after LASIK surgery. Of course, presbyopic patients we restricted to the age of 40 and 45. These patients should be highly wanting to get rid of their glasses, and there are many. What were the first patients we came across? In my practice, these were the patients who were reading the newsreaders, patients who were lecturers. They wanted to look at the class, they wanted to read on the table. A newsreader wanted to look at the TV, what the screen which he reads, but he wanted also to face the camera. These people brought us a new group of patients in a LASIK group, which were much more than treating or advertising presbyopia. We were treating a different age, which we feared will be unhappy after myopic LASIK. That gave us an encouragement, and we never left this way of treatment, even if presbyopia treatments went out of vogue because of reversibility or inability for the patient to accept it. Of course, Dr. Kumar mentioned excellent exclusion criteria, and they were same as anything for a refractive surgery, but patients should be well determined, well counseled, and willing to get it done. But we force this treatment on the patients coming in a pre-presbyopic age or early presbyopic age, because they are going to be happy on the very first day after their myopia has been corrected. Next day he's going to come say, I cannot read. So we had a different group of patients which we were managing. That's why concepts of custom Q treatment gave us an idea of presbyopic treatment, gave us a wider range how to follow and what we could do with assist nomograms and creating a new profile on our pupillary zone for the patient. Now, this is a hyperopic patient who came to us. He was a happy patient. He could see distance but was unable to read. So his best corrected visibility was 6.6, both eyes, and could not read. This man did not want glasses. We followed the assist nomograms. We did the calculations. Again, the delta Q was calculated. We aimed at -1. This was given to us that we got to aim at -1, but we were concerned about what was the delta Q. We saw that delta Q never went more than -0.6 to 0.7. These are the earlier examples where we learned that we should not increase delta Q beyond 6. And virtually we were treating a good laser correction on a dominant eye. This is how we started in the beginning, where we used to treat both eyes. There were good results, but not very satisfactory. Then we started treating only the non-dominant eyes, where we could easily calculate the delta Q. Just see, this patient had a 0 pre-Q and his delta Q was -1. We feared that we are going to virtually end up in problems with this patient because we will be treating much higher correction, and we treated just 4.6. Now, myopic patient, 43 years old. Who will treat this patient? Either you create a monovision or you give him a profile which could leave him satisfactory after he has been corrected with a good LASIK surgery. And what with us? He had a presbyopia of 1.5, good visual acuity, but if we correct his distant acuity, he is going to be the least happy patient with us and probably will stop many normal myopic patients coming to us. And we proceeded with aiming again, creating a delta Q value, which was within range, creating a monovision for him with adjustment of GQ, and virtually we were treating this for him. And this was on a non-dominant eye of this patient. So we were able to calculate what to treat. We didn't have a software. We didn't have something in the machine. Though Dr. Kumar mentioned now Alcon is coming with what is ready in their machine, but that will cost again. It will not be free to you. It will definitely cost to get it. It will definitely cost to get every treatment. This was the profile. Just see how the profile changes. And virtually you get, by enhancing the Q value, this is the Q value here. And you get a very good profile, which is hyperprolate and good, giving you a multi-zone treatment in the pupillary area, virtually creating a multifocal pupil for you. Now, this patient again, who will treat his complete myopia? Either you create a monovision for him or you treat his non-dominant eye for enhanced Q value, not treating any presbyopia for him. And this is what we just treated his delta Q. We just treated his delta Q. And we did find that his cornea gave us good results. What I want to convey is, do you really need a machine who has inbuilt software to correct presbyopia? Do you really need to spend on every treatment? No. Just pinpoint yourself, little work extra on your custom Q treatments, all who are using Allegretto, but even custom Q treatments are available in every machine. Q value adjustments became a customized procedure for us. It maintained the post Q value to same pre-Q value to reduce the spherical aberrations by maintaining the prolongedness of the cornea in a normal myopic patient. We practice this in every patient. If the pre-Q value was minus 0.2, we saw to it that the post-op Q value in a normal myope doesn't become oblate. It is brought well to the initial pre-Q value. This gave us a very good customized treatment and a happy patient. And of course, above all it, we got what was one of the ideal monovision procedure for presbyopia at no extra cost. Thanks to the SS nomogram, thanks to Gatinal mathematical modules giving us what we can treat. We could manage and definitely we could manage and definitely we could treat, customize for every patient. Wherever we found that we are ablating extra to maintain a Q value, we could reduce the Q value or reduce the sphere accordingly. Thank you.
Yeah, I think Dr. Dhami, this is an excellent presentation. I think you covered everything about the Allegretto, utility of the Allegretto on custom Q platform. I love that custom Q software. And 2 or 3 questions before Dr. Gaurav comes in. Number one is, let us forget about presbyopia to begin with. A patient comes to you, a myopic patient comes to you with this mesopic pupil size of 7 millimeters. And then he has got Q value of say minus 0.4. How do you manage him? Do you go for the wavefront guided treatment or custom Q value or wavefront optimized treatment?
His first thing you have to, he is a patient who is unfit for LASIK. He's got a large mesopic pupil.
Yes.
Right? He's going to create a problem for them. You can solve his problems by maintaining his pre-Q.
Q value.
Q value.
Okay.
Whatever it was, whether it was minus 0.4, we can maintain it and treat accordingly. I think we can manage to some extent the patient.
Fine.
But
what will be the ablation difference between the optimized treatment versus Q value, Q treatment?
That's what we manage. Accordingly, you will have to manage the spherical equivalent to treat that patient, reduce the sphere and manage it. That's a little problem, but it can be managed because the patient is already in trouble with the 7 mm pupil. He will agree to everything what we do for him.
Okay. Having gone through different, experimenting different delta Q on different patients at different eras, where do you do it? In one patient, delta Q was only 0.2 or 0.25 you created. Another patient you went up to 0.8, minus 0.8 for that matter.
Yeah, I think, let me interrupt you. The 0.2 was maintaining the pre-Q.
Okay.
And 0.8 was when you were exaggerating the Q value.
Okay.
To a required desire.
Fine. See, for example, there is a patient who came with 0 Q value. Would you consider him for presby treatment at all, or you will refuse him? Because
first thing, a patient has come with a 0 Q value. He is an ideal patient on a custom Q treatment.
Okay.
Because you can definitely give him a better vision, better pupillary zone by maintaining his pre-Q value to either to -2, or if it is going to be presbyopic, enhance it further to treat him.
Yeah, excellent.
But all depends on his initial K readings, what you can treat, what you cannot.
Okay. The other question is, what if it's already minus 0.5 Q value? Would you consider, or would you say you already have it?
Patient is myopic. I understand, right? Patient is myopic. I'll try to
small myopia.
Small myopia.
Minus 0.75.
Okay, but definitely maintaining his pre-Q value is the most important point for you to treat even small error.
Okay. See,
he will love that hyperploidness you have created by correcting minus 0.75.
See, I'll give an example. I had a friend a long time ago, 25 years ago. He was at that time 55, 60. He had 6 and 5 vision. I was always wondered how is it possible. He had wonderful. He never used glasses. For distance, I've done refraction on him. I don't know what's good or bad about his cornea or the pupil or lens, but he never used glasses. And to take my own example, I've never used presbyopic glasses.
Yeah.
So I was curious to know why is that. I can see reasonably well for distance. My distance power is around 0.75 in one eye and 0.5 in the other eye. I should be wearing in my age around 1.52 addition, but I can read, I can pick up 10-0 Nylock sutures from the field much better than my assistant who is 20 years younger to me. I looked at my cornea. I have a Q value around minus 0.42 or something like that. So probably that is giving,
Yeah.
very focal vision to me. And I've never used presbyopic glasses all along.
Yeah,
So
that's what exactly it was. These are the imperfections which give you a better depth of focus
Correct.
and better life. I tell you, it was somewhere, I don't know, Gaurav must be remembering, we were with Professor Theo Saylor. We were in a session of Q value, we were only 4 people in the hall. And Professor Theo Saylor was giving the lecture because we knew something in our machine which we could do it. I was deadly after it that I'm going to follow it. I have nothing more than this.
Okay.
Then he told me that this Q value, if it cannot treat cornea, it has to come into the lens. And virtually this is what we are going now.
I love this ASIS nomogram. I always use this in my cases. But in the original article, ASIS has mentioned that you'll have to do it in both eyes. You are mentioning
Yeah,
about
I started in both eyes, but that was little dissatisfying for me from the very
You've
first
done
day.
it in both eyes.
I had done it beginning, I've done it in both eyes.
Is there a possibility of doing, especially in those who have lesser minus Q values, like -1, -1.5? Is it worth doing half of the full correction? Like no, you're telling about 0.6, -0.6. Is it worth looking at -0.2 or 0.3 in the dominant eye? Have you tried that? Undercorrecting Q value corrections in the dominant.
Yes, I have tried that. Moment we exceed our ablation profiles, the amount of tissue being ablated by enhancement of the Q value, we decrease the Q value. That was the value of this software.
Okay. Okay. See, Dr. Kumar doctor was telling about the stability of the cornea after doing a varifocal corneal ablation, multifocal ablation. What is your experience in following up of their? I see that you use OPD3 scanner. That's an amazing one. It's
Amazing.
both wavefront picture as well as topographic picture in one view. We use the same this thing. What's your experience on changes in the wavefront and changes in the cornea over a period of time?
Is it I to answer or Dr. Kumar?
Your answer. No. Kumar has answered that, but
No.
he says that it's going to change. But what's your experience?
See, I really don't have a
answer for that.
OPD3 from NIDEC.
Okay.
I use my Vario now to calculate what I'm trying to treat.
Okay. I saw one of the photos which mentions OPD.
Yeah, I had taken that to explain.
Fine.
Yeah, I had taken that to explain the inequalities in the pupillary area. That's what you said you are having it. That those are the imperfections which give us an answer what we are treating.
Great. I think there are many ways of handling presbyopics, and you did mention about the utility of the platform. How do you take the possibility of titrating the optical zone? How do you relate it to pupil size or the myopic power or hyperopic power? Do you play with it? Because there is a possibility of playing with it in presby correction, or do you keep it 6 mm all the time?
We try to keep it to 6 mm, but as Kumar mentioned, pre-op pupillary diameter is something which should make you strike you that I'm going to be happy or not.
Yeah, you did mention, both of you mentioned that what are the case selection, what cases you refuse to do it. You don't want to do presby LASIK in such, you told about psychological factors, somebody who is not motivated. And what is the status of binocular vision? Do you assess binocular vision before this?
Yeah.
What if the patient has a slight intermittent squint or exotropia or esotropia.
No, one advantage of the last point you mentioned was the variotopalizer now. It takes care of the angle kappa, right?
Yes.
That part is very well settled now. And the second portion was the disability he's going to feel with the monovision or whatever you call it, right? And you remember that he's going to be in problem initially with having one monovision eye and distribution. I remember Dr. Siri Ganesh being got operated.
Yes.
And first thing I sent him a message, what is your refraction? He said it is minus 1.5. See, then that assured me that this is maximum. I think you should limit yourself. This SS nomogram will tell you what will be the residual error. I think that should be the idea to practice. But these people are going to be hampered and disabled in their depth of focus to some extent. If you can create that preoperatively by doing a good chair work, 2-3 sittings, and asking him, how did you feel? You will have an answer.
The reading habits of today's population, including all of us, has changed a lot. We hardly read books now. We hardly read print material, where the contrast has to be good, distance is optimal. Now everybody is into digital screens, where we can magnify, we can illuminate, we can do all of things. The need for Presby correction has come down. Many people don't come for glass correction till the age of 45, 50. They manage with modifications of the screen. So do you think we will be looking for more and more, because Presby LASIK does not correct 2.52 and give the best vision for 18 and 20 inches distance? I mean, is this a time when we have to tell our counselors to counsel Presby LASIK treatment more often?
No, I'll add a point here. Look for patients who want to play cards,
Okay.
who want to give a lecture
Okay.
without wearing glasses. All politicians.
Okay.
And all teachers, all ladies who don't wear glasses at the parties. These are the patients you should aim at. Don't aim on a patient who's really interested in reading. No, I don't think so. Even a multifocal won't do in that.
A patient with very little cataract comes to you, very little, you hardly have to magnify and pick it up. What do you call
you were talking about a dysfunctional lens.
Yes. Would you prefer to do a multifocal lens, or would
I'll
you prefer
a multifocal lens. Clear lens extraction.
Fine. I think Gaurav, you can go ahead with your talk, with your experience.
Can I say one or two things?
Yes.
Yeah, please.
So what you said, Dr. Ravindran, about your ability to read after 50 and you didn't need presbyopic glasses, there is a method where you can measure your pseudo accommodation.
Yeah.
And it just means that your accommodation is more powerful than the others, and that's the reason why you really didn't need glasses. So there are some wavefront analyzer technology machines which actually measure your accommodation, and you can actually see. So even these patients who we are doing presbyopic LASIK, you should actually measure their accommodation.
Okay.
If you can really measure their accommodation, that will give you even more results or bad results or good results. And one thing, sir, I wanted to tell you, Dr. Dhami, actually what you're creating is a multifocal cornea. Am I right?
Yeah.
The Q value.
Multifocality in the cornea. Yes.
But how do you control the size of this multifocality? So your center is how many millimeters? Then comes
it's 1.5. By whatever profile take, it's about 1.5 as the apical paracentral, and 1.5 around it as the next zone.
So the wavelight is
because
what is the spot size of the wavelight laser?
I think it's
less than 0.9 it was. Now it may be smaller than that.
0.7, I think 0.8.
0.7.
Like
0.7 on the 500 hertz. Yes.
Yeah.
0.7.
See, once you are creating a sphericity correction, you are virtually creating what you are trying to tell me is a zone. See, a zone from the apex to the pupillary margin with the power increasing in the center and decreasing towards the periphery. That's what we do.
No, I think there is no zones, fixed zones here. Because,
no fixed zones.
No, it's a continuous from, as I said, it's continuous from the visual axis towards the edge of the pupil.
Edge of the pupil, yes. Yeah. but it is labeled as multifocality in the pupillary area. That's what Gatineau has labeled it.
What is most interesting is I have never tried maintaining the same Q value in a myopic patient, in a non-presbyopic myopic patient. I've never tried that. I think, have you done a lot of them, Dr. Dhami?
I have done that, and it works well.
Have you
Dr.
done in
Dhami,
one
I
eye
wanted
this
to
way
ask
and one
you-
eye optimized?
No.
No. Okay.
That's exactly what I wanted to ask,
Always
because even the wavefront optimized will usually try to maintain your Q value to where it was. So that's what was the whole purpose of doing the optimized treatments or the aspheric profiles, because you would try to preserve the Q value to what was pre-existing, because otherwise in the older machines the myopic ablations would actually make you flatter
Lot more.
corneas and make oblate
Dr.
corneas.
Gaurav, if you measure it, actually there will be a huge difference. Though
Huge
it's less than, it's not creating a positive asphericity, but when you measure it actually pre and post-op,
There would
there is
still be
a
some
definite drop. Yeah.
absolutely.
And the,
So even that,
tropo picture
Even-
also, this way and that way are different.
Even Dr. Gaurav, the wave Alcon now is trying to impress upon, try to shift to custom Q, where that's a better profile even than wavefront optimized.
Are there any special indications for retaining custom Q, Dr. Dhami? Which myopes do you choose for that kind of treatment?
See, you have already measured a pre-Q,
Hmm.
and if it is already going into positive spherical aberrations with the myopia, and the flatter you create a cornea and a high myope or a low myope, I think custom Q will have the values.
Okay. And how do you manage your decentered Q values? Like, it's not in the center, you have decentered pre-existing Q value,
Not done many, not really worked on it.
But
It's
decentration
something-
of visual axis becomes very critical, because
See,
there are so
we-
many
we-
changes.
we were lucky that we centered. Now we have a variotopolizer which is very well centered and prevents all the decentrations. I think you have been using more of adjusting the ablation
Visual axis.
profiles.
Yes.
That's what you can do.
So you use Vario for
Yeah.
automatic
Even
correction.
manually you can do it. You can do
Manually.
it.
Dr. Kumar, how does Schwinn do with these, especially when you're handling the hyperopes? Their Q value is pretty high.
I
So
think
does the
they
machine
are-
automatically send us
Yeah,
to the
they
visual axis?
automatically do it. We just feed in, as I said, micromonovision gives the best result as far as Schwinn goes. So we don't do this calculation, and actually it is creating a multifocal cornea. So if you have a little different direction of light, you can see different zones. It's actually like a refractive surface and not a diffractive surface. We can actually see that on the surface being done.
Okay.
That's what they are charging for, I guess.
Okay. Dr. Gaurav, your
Yes, sir.
experiences.
Yeah, so I was going to give a bit of a counterpoint that, after having done Presby LASIK, I mean, the Q value adjustments for almost 15 years now, I'll just share my screen and, maybe I have just 5-6 slides to share because I just wanted to share how we've gone through this. So, okay. We all understand this, so I'll just skip all this. And these are all the ways that we can use Presby LASIK. So we started way back in 2002 with the 200 hertz. And, we started by doing myopes with micro monovision or even monovision. And, we've over the years, like over the first 2-3 years, we realized, I think that's the time when, Dr. Ravindra and Dr. Dhami were already using the machine when we actually started using it. So we were actually learning for both of you. And we realized for ourselves that we have a fair number of hyperopes in our area. From surrounding cities, that we have a population which is significantly hyperopic. So we ended up doing quite a significant number of presbyopic hyperopes, and we realized that they all do very well. They end up having a hyperprolate cornea with very good near ability. So even when we were not having custom Q, we were ending up having lots of hyperopes, as Kumar said, who would naturally have, in their 45s or 50s, who would not need reading glasses post-op when we were just aiming for emetropia. So that was amazing for us because we realized that, it was a learning experience. So we knew that hyperopes are going to do well even when you're not customizing the Q values to that extent. I think in 2004, we switched on to the 400 hertz with the custom Q. And that was great because, that's the time when we started aiming, playing around in the 2004 or 5 with the custom Q protocols. And we started also doing some adjustments for the myopes and the presbyopes, as Dr. Dhami suggested. We did not have the benefit of the nomograms at the time. So at that time, it was always, taking -1 for the Q value, as Dr. Dhami suggested. But we did end up often going wrong with the refractive results because, they would sometimes be off and that would lead to some dissatisfied patients. So we had a mixed bag. We would have some very happy patients and we would have some not very happy. And then we were also doing this only for one of the eyes and we were not making the other eye absolutely, aiming for a -1 at all, which is probably the correct way to go. And yes, of course, we did delve with, CK for, when it was introduced in India somewhere in 2005 or 6. I remember Monish, bringing in the machine with the CK guy. And we did like a month of trials with that. Luckily, we didn't buy that machine. And, we look back and I say that, I was happy that we did not. We then also played around with the inlays somewhere a little later. And I think what has stuck on since then is that, we actually don't kind of look at patients who are aiming for presbyopic correction, because when we start offering presbyopic correction to patients as an option, they end up having usually dissatisfaction down the line. If not right then, they might do very well at that point. But, over a period of time, they'll come back complaining that, I can't read anymore. So if you offer that as a presbyopia solution, that is always going to be a problem. But by default, all patients who are being treated in the pre-presbyopic or presbyopic age group, we would offer them some kind of, ability between monovision or a custom Q value. So there are limitations of presbyopic monovision corrections, which we were doing in the beginning, because you can't go beyond 1.5 as everybody has suggested. Also, for patients whom you're promising some kind of near ability, if you are still offering them a monovision, some of them will probably come back with, problems with different discomfort with intermediate vision, loss of fusion, inability to see the fine prints, or even loss of stereo acuity. So there are limitations. And yes, I do use monovision quite a bit. It works well, even with my cataract patients when we were not doing as many multifocals. Today, I think my monovision in cataract surgery is very small. So I think, we all understand now from Kumar's talk and Dr. Dhami's talk, and I think with Dr. Ravindra's experience, that Presby LASIK works best in hyperopes, and it naturally works even when you're not adjusting the Q value. And if you're doing that, then it works even better. But what about the myopes? And I think Dr. Dhami's talk was excellent there, because that's what I was trying to do many times with the custom Q treatments. But as we were, not getting consistent results, we were not getting consistent happy patients. We've just stuck onto that without advertising it. So most important thing for me is that we don't tell our patients that we're going to play around with, giving you presbyopic correction. We just tell them that since you're presbyopic, these are the limitations you're going to feel. We will try to do something for you to improve your thing. And we go ahead and do custom Q adjustments for them without actually advertising it or promising anything. And then what about the emetropes? Now, this is the biggest group of patients who starts coming to you when you try to talk about Presby LASIK or presbyopia solutions, because these are the ones who will, typically come up and say that I want to do something. I don't wear distance correction at all, and I'm plano, and I have presbyopia. Why don't you do something? And this is the group which is most difficult to tackle, actually, for our machines. At least I use the EX500. And of course, patients who are getting older and having progression of presbyopia are the ones who will probably trouble you within a year or two of getting it done. And then, of course, we have to deal with the regression. We are understanding this more and more with epithelium thickness mapping, and it gives us a lot of insight. And as Dr. Ravindra was telling Kumar just now, and yes, dissatisfaction rates are high if you advertise it. If you don't advertise it, these patients tend to do well. And although Kumar said that his machine offers that principle of reversibility, I don't think our machines do that at all. And they are irreversible. And if you have a dissatisfied patient, he remains dissatisfied most often. So I think another challenge is cataract surgery after Presby LASIK, although this has been used as a selling point by Presbeyond and other technologies where, they say that you can easily put a monofocal lens after the cataract surgery. However, there may be a problem with IL-PAR calculations, getting emetropia for these patients, which formula to use, and having potentially dissatisfied patients. But this is all hypothetical because I haven't actually seen this patient. So I would love to ask this question to Dr. Dhami and Dr. Kumar about how they deal with these patients. So in our practice, I think we are very happy treating our hyperopes and especially customizing their Q values a little bit. And, so we are happy to treat our patients who are pre-presbyops and early presbyops with custom Q corrections. And, the hyperopes do quite well in the late 40s, and in the 50s, we have gradually moved on because newer technology, multifocal lenses, the trifocals and continuous range of vision lenses have been extremely good. So we've had good results with the refractive lens exchange. Our myopes, I think, are the ones where, with especially the high myopes or the anisometropes, we love to give them, corrections where we are giving dominant eyes as full corrections and the other eyes leaving them with they tolerate monovision really well. And they actually are very, very happy patients if you kind of do a little bit of touch up with the custom Q and also give them a fair amount of monovision. But also some of these patients will do well with the refractive lens exchange, but multifocals may not be a great option. I end up doing more of eye-hands lenses for these patients. Emmetropes, again, a problem because, this is always the group. So if in the 50 plus age group, I will not hesitate to offer them a refractive lens exchange. If the problem is with those patients who are before that, and, if they're emmetropes, rarely I have done a few patients where we've done one eye after doing a monovision trial and given them a correction. Some of these ladies have been happy, but most often we don't end up treating the emmetropes less than 50 years in any case. So I think these are the challenges, the emmetropes, the young presbyopes, who are likely to come to ask you for some treatment once you start talking about presbyopia solutions, and we have to watch out for those. So these are the challenges which I thought I would discuss, and why presbyopia corrections have not really taken off in a big way as they should. But I'm sure there is hope, and we do have some solutions available to us which we can offer without really promising anything. So with that, I'll stop sharing and we'll hear Dr. Ravindra share his notes. These are just thought-provoking ideas that I thought I can share with and listen to what Dr. Ravindra has to tell us.
No, okay. I think it's a wonderful, conclusive, analysis of the entire gamut. I would ask all the faculty, all the speakers, is presbyopia is everybody has to go through it. Myopia and hyperopia are choose selective things, and the reason why presbyopia is not very popular is because we have not tuned ourselves into talking to the patients or training our counselors to talk about presbyopia treatment. We are sort of subconsciously scared of the results. With Dr. Dhami's good results, and with Dr. Kumar mentioned about his experiences, we should be able to boldly talk about presby LASIK for these patients, especially in hyperopes. Of course, in emmetropes and myopes, as Dr. Gaurav summarized, the better options after the age of 50 is clear lens extraction. But as the technology of clear lens extraction is the lens extraction itself, cataract extraction, the availability of IOLs is drastically changing. Last 3-4 days, we have seen leaps and bounds of improvements in the IOL technology. Are we depriving these patients by doing a trifocal lens or a current technology DOF lenses of the future developments in the lenses? Another thing we'll have to keep it in mind in the borderline. I think the best is to leave it to the patients to decide, give the inputs to them, and basically we'll have to, like in our own clinic, if a presbyopic comes in, our optometrists are very happy to prescribe a pair of glasses. They don't talk about LASIK at all. They don't even mention about it. Sometimes even the patient asks, can I get a LASIK done at the 42? And my standard answer is, anyway, you have a little bit of cataract, wait for another couple of years and let us do a cataract surgery. That's the mindset that we have, that we are not taking these patients into the LASIK platform is probably one thing. We can easily double our numbers by considering presbyopics as potential LASIK patients. A few questions here. Dr. Dhami, you did a flap LASIK on pseudophakics. So do you consider surface ablation at all in these patients, number one? Number two, the differences in Q value is only in microns. So when you raise a flap and put it back, are we going to dilute when the flap sits back, ultimately after the treatment? Would it be same as the pre-existing flap, or would it be better off doing it on the surface without raising the flap? This applies to not only presbyopics but all presby LASIKs, not only pseudophakics but all presby LASIKs.
Question is doing a surface ablation. It's very easy, but the remodeling of the epithelium itself takes away the effect of Q value in the initial effects. It takes a long time to get the epithelium remodeled to the Q value you have adjusted. The aphesericity changes when there is hyperfluorescence because of the remodeling of the epithelium. That's a big factor one has to consider. That's why making a flap like Dr. Kumar showed is a better procedure.
Okay,
And
Dr.
thanks, Kumar, saving the epithelium. That's the first time I saw. Thank you very much for that.
Dr. Gaurav, would you consider doing surface ablation as a better option than flap, or do you have anything to say on that?
Enjoy doing surface ablation if I'm going to operate soon on a pseudofake. But if I'm doing surgery maybe 6 months down the line, and if I have like astigmatism to deal with or something, since I don't do as much presbyopic correction, and especially not on a pseudofake, I think Kumar is the only one who actually does it. But if I had to do that, I would consider surface definitely if I was dealing with a patient who's an early pseudofake. But if I've had a patient, I will not hesitate to make a flap because sometimes they are more predictable, especially because we end up doing this more for astigmatism than for spherical errors when we do it on pseudofake. So I do both. I do surface and femto flaps as well. And in fact, even smile for a few patients that I've done. Yeah.
So one comment I wanted to make, you talked about monovision as far as a presbyopic type of treatment goes. And you know that Sri Ganesh has ultimately got the Presbyon done. And even I had asked him the same question. He said he'll have a sensor or a aspheric neutral lens whenever he gets a cataract. But don't forget, today is using glasses to operate on the 3D microscope. Otherwise, he can't operate on the 3D microscope.
In fact, Kumar, I was reading through Presbyon before this meeting happened. I had some data on Presbyon and I was going through it because it was not being covered in this and I thought I might be able to add. What I understand is Presbyon actually is basically aiming for emetropia in one eye and aiming for a minus 1.5 in the other eye, and then doing a blended treatment to increase the depth of focus. So it's not as if Presbyon is going to do some kind of presbyopia, multifocal cornea or anything like that. It's basically monovision of 1.5 with a little bit of extended depth of focus. So I don't know if it's really any vastly big in a big way different from creating a micro monovision or a monovision. Really, it's probably just pumping up that a little bit, but maybe my understanding is very less and I don't actually do the treatment, so I won't know. But this is what I kind of understood from that. And
probably
and
it
Sri
is
Ganesh was a
something.
hyperope. See, Sri Ganesh was a +1 hyperope. So when he got a correction done, he obviously, aimed for, on the dominant eye, he aimed for a emetropia, and in the fellow eye, he aimed for a minus 1.5. This he's likely to be very happy anyway because his cornea is going to be hyperprolate anyway in both eyes. No.
Yeah. So point here was that he needs to wear glasses to do 3D surgery on the microscope and for driving. So it is like a monocular only, and that's why he's lost depth. And that's the reason why they need the glasses. So they have to wear the distance correction to do 3D surgery on the screen. So that compromise comes, he's got it done many years back, but that compromise is there.
Yeah, I think the pupil was discussed enough. They should not have very large pupil, but is there any limitation for the smallness of the pupil? If the pupil is too small, like often you see pupils are 2.5 millimeter, 3 millimeter. Will these people naturally they have an increased depth of field? So would they benefit by? Is there a contraindication on the smallness of the pupil size, Dr. Dhami and Dr. Kumar, doctor?
In my machine, it's 2.5 as a cutoff.
Okay.
Less than that, it's a no. It's a contraindication.
That is the photopic people.
Okay.
Dr. Dhami?
We try to maintain is 2.5 to 4.
Okay, fine. Dr. Kumar, you mentioned about pseudo accommodation. Pseudo accommodation is seen in pseudofakes also. They also a lot of pseudofakes who are targeted around 0.5, 0.75 with a little bit of cylindrical power. They don't need glasses. They prescribed and they keep it. So how do you measure the pseudo accommodation? You did mention about a machine, wavefront machine.
So I have an outdated aberrometer, smiling eyes, made by a French company.
Okay.
It actually measures accommodation. So it shows a target and then it moves the target.
Wait.
And then it actually displays the dioptric range or the strength that you are actually accommodating. So that's how we are measuring. And as your comment said on pseudo accommodation, actually it's not only the strength of the ciliary muscle, it is also the optic haptic design and the material of the haptic. So some of you might have used the Pharmacia lenses, which were holder and folder. They didn't have an injector ever. Those lenses had excellent pseudo accommodation because of the design of the haptic, and the whole haptic was made out of one molecule, one polymer, and that's the reason why they accommodated. But if you go to another kind of lenses, then they do not have so much pseudo accommodation. So it's not only the lens, it's also the lens design, is the lens material, and the strength of the ciliary muscle. And I measure it because I have this machine which actually measures the accommodation.
Excellent, excellent. We'd like to see some photos of the charts that it gives, if in the near. The other thing is, the one other thing that contributes to the depth of field or depth of focus is the amount of astigmatism. Imagine a patient comes with pre-existing hyperopia, myopia, whatever it is, and he is opting for the increased, depth of field. Would you consider leaving behind a 0.5 diopter of astigmatism if he's existing, or if he's an emmetropic, or if he has got a spherical power? Would you induce a minus 0.5 90 degrees as an option?
You want whom to answer?
Anyone.
Kumar,
you can answer it.
Actually, one method of giving a depth of focus is creating minus 0.75 to minus 0.5 at 90 degrees.
Okay.
You create, Dhami?
Yeah.
You create.
You create.
That's interesting. Can you give more experience, more of your feedback on this? In what, like for example, he has come with, he's got a power of +1 in both the eyes. You're going to treat that, and in one eye you're going to treat into 0, the other eye you're going to target minus 1.5. Imagine that's a scenario, monovision. So would you create a 0.5 D cylinder?
No, that we have done only in pseudophakics.
The pseudophakics, fine,
yeah.
Okay. Dr. Kumar, did you ever think of creating an astigmatism?
No. I have not done this, but I will look. I think I will think on this. But vertically steep, I undercorrect by half.
Undercorrect by half. That is, you're retaining half diopter of power, the cylindrical power.
Yeah, and horizontally, I correct fully.
Okay. Is that because the cornea is going to become more and more against the rule astigmatism with the age?
Yeah.
Okay. Good point. Dr. Gaurav?
I tend to, since I'm doing a lot of toric IOLs now, I tend to go with the Barrett's nomogram because that ends up doing this automatically, what you were suggesting. And yet I don't purposely create or leave astigmatism. I would go with, I've had excellent results with, using the, current nomograms that I'm using. Patient satisfactions have been amazing. I even correct 0.5s of against the rule, and I undercorrect the ones of with the rule, and that gives us very good outcomes.
That's a good point, because when you're younger, the contrast vision is very important. You need to be very sharp vision. That's what they look at. But as you grow towards 40 and 45, what becomes more important, more than contrast vision, you need more depth of field. There is a shift in the philosophy, and in that age group, we can consider, as Dr. Kumar mentioned, leaving behind half diopter of astigmatism to enhance the depth of field. Presby correction is becoming an issue not only in LASIK surgery but also in cataract surgery. Is there any similarity between thought process of what we do in LASIK versus what we do in cataract? Dr. Dhami?
Yeah, I think there's a lot of difference.
Lot of difference.
In cataract surgery, whether you do a refractive lens exchange at any age, is something which is going to get it for whole life. And in Presby LASIK, he has a period to enjoy.
Yes.
And that period you got to explain to him that you're going to enjoy only this.
Okay. Very good. Dr. Kumar, would you consider the knowledge you've gained in LASIK in cataract surgery, or whatever experience you have in cataract surgery, you bring it to the LASIK platform?
No. I keep them separate.
Your thought process in both are totally different.
Yeah, because I still feel cornea remodels over time.
Okay.
And I would request Dr. Dhami, actually what he has done, because he has vast experience, now we are concentrating on epithelial thickening,
Model.
mapping, etc. But if you get some 5-year back Presby LASIK done and then take an image today, you will see a lot of difference, is my thought process. And
That's
that is
why,
actually what is
that's
carrying.
why you got to explain a time limit to the patient.
What, sir?
You have to explain a time limit to the patient.
Yeah,
That you're going-
Time limit.
So, but if you
Problem-
explain a time limit to the patient, don't they kind of fall out of it? Like if you tell them
Yeah.
that in 2-3 years you are
Yeah.
not likely to,
And
they'll
They-
probably
They'll ask a refractive lens exchange.
And no, the
Yes.
problem there is if you are doing Presby LASIK on a pseudo-phakic eye, and then you explain a time limit, they're not going to be happy. Or a higher retreatment rate.
Yeah. That is the reason it doesn't work in all, and it is not, should not be advertised.
Dr. Kumar, you mentioned about a multifocal contact lens. What's your experience in it, and what kind of multifocality that contact lens induces in the eye?
Sir, we use any of this, Johnson & Johnson or SIBA.
Okay.
They have a low ad and a high ad and a medium ad.
Correct.
So let's presume a patient is +1 and a +1 in both eyes. Then in the non-dominant eye, we will either, depending on whether we want micromonovision, hybrid or monocular, we'll fully correct. So that non-dominant eye, you can give a higher ad. In the dominant eye, you give a lower ad. And then we give this trial for a week. And if the patient is comfortable, because his distance vision in the dominant eye from 6.6 will become 6.6 part or 6.9.
Mhm.
And the near will become, of course, N5, N6, whatever you have corrected. If he's happy with this, then only I consider that patient will be comfortable, provided all the other criteria are matching in. And that's why I feel the volume that we are getting here is not very, very high. And that's the reason why I guess we're not able to do it that often. This is my thought process.
Fine. There are a couple of questions in the chat box. I'll just read them out. What is the percentage of regression in Presby Max, Dr. Kumar?
I had almost 22% in 2010.
Okay.
And,
Will the
so
procedure? Yeah, go ahead, please.
sorry, sir. What were you saying?
No, carry on. I was coming to the next question.
That's the reason why the retreatment rate then was quite high. And now whatever we have done recently in the last 2-3 years, my retreatment rate must have dropped much lower to about 5%. But as mentioned by Dr. Dhami that, we may tell a patient for 4 years, but they need a retreatment in 2 years. Then what are we going to do? So these are the points that come, and Shin charges for every retreatment. It doesn't do it free. So even if I do a retreatment in 3 months or 6 months, Shin takes the money.
Yeah, the custom queue is free. It's a free software, and we can really work on it. And did you had any occasion of looking at the Q value before and after treatment with your Presby LASIK?
No, I'm not doing that.
Not done it. I think it's better look at it and just find out how much of Q value it's changing after the treatment. Will the procedure have any effect on the biometry for IOL calculation when the person needs a cataract surgery in future? How do you go about? All of you can say the person has had a Presby LASIK done, and you already mentioned that you will take a non-negative aspherical lens. You choose the lens for that. Can you give me more details on what kind of biometry you do, or you do use TrueNet power on Pentacam to calculate this average central corneal power?
I can answer.
Yeah, you can answer.
Yeah.
So, sir, recently I got one patient, Presbyopic LASIK, done almost 14 years back by somebody somewhere. Okay. And when I looked at the cornea, I saw no effect of Presbyopic LASIK. So then I decided to do our normal calculations of a myopic LASIK. And I went ahead and put a synergy lens, which is a multifocal lens. Which is fine. So what I'm trying to say here as a take-home message is, you may get a history of presbyopic LASIK. Don't go by that. Look at the topography, look at epithelial thickness mapping, and then take a call whether yes or no, what should be done. Because as I again mentioned that the cornea modulates over time and you may not see any effect. As far as the calculation goes, I did the TrueNet power from the Pentacam, but they also say that ray tracing, what I think Gaurav has, and all of you might be having, I don't have that machine, also is more accurate to give you the corneal curvature, etc., to get into the calculation. And then, of course, aspheric neutral IOL, not a aspheric correcting IOL or a normal spherical IOL should not be preferred for such patients, is my thought.
There are very few options for spherical IOL, aspherical neutral IOL. Sensor you mentioned is a positive aspherical lens. It's
Greener is aspheric neutral.
aspheric neutral, yeah.
Botulinum is aspheric.
Yeah.
Bausch and Lomb has got, yeah.
Yeah.
Sensor is positive aspherical.
Yeah.
So that's a very interesting answer. He looks into the TrueNet power and the pentacam. We look at TrueNet power and the pentacam, of course, but TrueNet power and this pentacam, we only look at the pupillar area, not the 6 mm zone. You pick up all the points in the pupillar. Yeah, go ahead, doctor.
We look at the 4.5.
4 point. No, actually, I get a printout. I look at the pupillar area, count all the points, K readings in the TrueNet power K readings in the pupillar area, take an average of it, calculate into. There are 9 points, there are 21 points. There are 2 pictures come, and I calculate on Barrett all of them. I calculate for 9 points. I calculate for 21 points, and we also have OPD3 scan. There is something called effective central corneal power. So what it does is it looks at the cornea, and then the peripheral corneal curvature and central corneal curvature is different. So it will project a normal cornea on it and calculate the effective central corneal power. That's one reading I take. And also there is a pupillary area power it gives. All the 4. The difference is going to be 1 diopter between one to another one. I go to the middle one and take that as a effective IOL selection. For my cases. There are 4 or 5 readings are generated and you take the average of them. So that has given reasonably good results. The next
Does it always match or sometimes it doesn't match? You have these 2 modalities. If
Yes.
they don't match, what do you fall back?
They don't match. Then I go more by pentacam readings. If they're far different, I go. I put all of them in one. 5 readings come, and then I take an average of it. But if they're different, like for example, 23, 23 and a half, 24, something else is 21, then I eliminate the one which is far away and still take an average of the 4. So what effect the procedure will have on operating surgeon under, I think you mentioned it. If somebody is going to do operation under surgical microscope, obviously he has to turn the dioptric scale on the oculus to suit his refractive error. I think that's what probably it has to be, or he has to wear glasses. Question to Dr. Dhami. You are using glasses. Why didn't you yourself opted for LASIK? That's a common question. So all of you have to answer that. Dr. Dhami, why didn't you?
I was a myope.
Okay.
And I was very happy with vision without glasses. I tell every patient, I'm very happy with my glasses.
Okay.
If you are happy, don't get it done. I am happy, I won't get it done.
Okay. Yeah, that's a very good answer. People ask us, what is the best one? LASIK best, contact lens, or this thing? I said always, for any person, glasses are the best.
Glasses are the best.
So it's your selection of what you want to wear, what you want to get it done. I think that's the answer everybody has to, tell to you. Dr. Kumar, how do you respond to that? If somebody asks, why didn't you get your power done?
In our presbyopic glasses, my distance is only a plus 0.75. My corneal pachymetry is very bad. It's 415.
Mm-hmm.
So anyway, I would not be a candidate for anything. So it's not going to be. Luckily, I don't have anything bad. Otherwise, it's sad.
That can be a hooked answer.
There's another question. Hyperopic patients, Dr. Kumar says he dilated subjective refraction he does on Tropico Plus, but I prefer to do, if they are undergoing a hyperopic LASIK, I always have a reading with homotropin dilatation. So I want to know what is the absolute reading there. Then I play around with how much to correct it. Should I correct the subjective dilated, subjective non-dilated, or much more than what is subjective subjective non-dilated? So I would, my regression rates are 0. I don't get regression at all in hyperopic because I do a homotropin dilatation test for any hyperopic, whether whatever may be the age, 40 or 45. There are surprises even at 40, 45. A person, I've seen 42 with the latent hyperopia of 2 diopters. So it's a possibility.
Oh, only then, sir, if you give hometropin, then you're not doing his LASIK for 3-4 days.
No, I would wait for 1 week. What is wrong in it? There's no emergency. So I'll tell them I would like to know what is the status of your eye, and we also do a biometry as a routine for all LASIK patients.
And we are
Everybody.
We are
So if you imagine it's a small eye, it'll give an inclination that, or if, for a flat cornea, for example, there may be hidden hyperopia in that patient.
Yeah.
So it is 11 p.m. I guess we should close. Yes,
Yeah.
we should close. Fine. I think all of you can say a few words about what is the future of Presby LASIK, as time passes. Dr. Gaurav, would you like
Yes,
to
sir.
come later?
Yeah, can you hear me? Can you hear me, sir?
Yeah,
We can.
Okay, so I think it's very exciting times for refractive surgery. So I have no doubts that we are heading in a direction where things are going to keep getting better and better. Our understanding is getting better, as we said, with epithelium thickness mapping. We are seeing more and more and beginning to understand how the cornea behaves in these eyes. So I'm sure we have a lot of potential of newer things coming up. So yet there is also a lot of development in IOL technology, and we are getting better and better lenses. So I think in every way, the presbyopes are going to have it better, whether be it laser-based procedures or lens-based procedures. We will have a better solution for them. And I did wanted to add a little bit here about epithelium remodeling, because I also see some of my patients who were operated with custom Q 10 years back, and today I hardly see any effect remaining even of that. So epithelium remodeling and epithelium thickness maps have shown. So what Kumar said, I would like to echo that, and that's, I think, my take on what I would like to say.
I have a question. None of us discussed presbyopic IPCLs or ICLs.
Maybe next
Kumar?
session. Next session.
Do you think they have a place?
I think I saw this, I've done the camera, and can I take 1 minute, sir?
Please,
Sure.
please.
So in Singapore, I was with who's a very famous refractive guy. He was putting a transparent 1.5, 1.75 in every other non-dominant eye, like a contact lens like a camera inlay, which is replaceable. So if you at 50, you may change it to 2.25. And now I don't know where. Raindrop was the name of the company. Raindrop, which I remember very distinctly, and I thought it was very promising. So I personally would love something like this. Make a flap, put a contact lens inside, and you're fine. Or not happy, remove the contact lens, and everything is okay. And there is no question of anything. So I have done 4 camera inlays, except one. All are doing very well. They've not even come to follow up. The beauty there is you get a cataract, just remove the cataract, put a normal IOL, and they can still continue to read with the same inlay. Surprisingly, I think camera inlays again disappeared from the world due to many reasons, vice versa. But I personally feel that, I don't know. I'm just, in my mind, I have a block somehow that cornea remodels. And that remodeling is very individual. You can't predict that how will that remodel. So that predictability, if someone can talk about, then maybe this will take a bigger boom.
Dr. Dhami, you can give us the final concluding remarks.
Thank you, Dr. Ravindra. I think if you do not tell the patient that you want to correct presbyopia, you're a good doctor for him. And he's a good patient. If you ask to someone to treat presbyopia, then his expectations are going to rise. And we will not be able to fulfill those. I do not advertise, I do not tell, but whenever there's a patient in that age, I explain him, this is the procedure for you. And I always end up nicely.
Do any one of you use Pilocar as a presbyopia managing mode?
No.
No, fine. Okay, I think we had a brilliant discussion. I think we had a lot of learning in this, especially from Dr. Kumar, who told about Schwind platform, everything about the 3 kinds of very novel kind of approaches, and Dhami mentioned about custom Q protocols, and Dr. Gaurav summarized his experiences over more than a decade's time. We had fantastic time. Thank you very much, and we'll meet again on this topic, and we'll try to meet in conferences where we can shake hands and smile at each other throughout the program.
Thank you for the opportunity.
Thank you. Thank you very much.
Thank you so much.
Thank you, Ravindra sir, and pleasure meeting everybody.
Thank you.
Thank you so much, everybody, for being with us today evening. Extremely thank you. We'll come back 2 weeks later from today, and we have covered 12 sessions and 12 sessions, and we have finished almost every single aspect of LASIK from refraction till the presbyopia treatment. And next week we'll try to have a grand finale with multiple concepts, including practice management, so that we have a finale for this season. We'll come back with more like what Dr. Dhami said, IPCLs and keratoconus and much more from JLVC, and we'll take a short break for a couple of months, and then we'll be back once again. Thank you so much, Dr. Dhami and Dr. Kumar and Dr. Gaurav, Luthra, Dr. Ravindra for coordinating. This is one of the longest sessions we have had in our sessions. It went on up to 11:30, I think, 11:20. Thank you so much, and bye-bye, good night, and God bless all of you. Bye-bye.
Thank you.
Thank you. Thanks, doctor. Thanks,
Thank you
Dhami.
very much.
See you.